Hello everyone and welcome back. Chalo, let's dive straight into today's high-yield explainer. We're tackling a seriously massive topic for your exams, unruptured ectopic pregnancies. We're going to take those dense textbook pages and handwritten notes and just totally decode them right here into a crystal-clear digital revision session. From the exact diagnostic criteria all the way to the absolute latest management protocols. If you've ever been sitting there confused about exactly when to give methotrexate versus when to rush your patient into surgery, dhyan se sunna. This is your ultimate rapid revision.
Here's our game plan for today. First, diagnosis and TVS. 2. The beta-HCG algorithm. 3. Medical management. 4. Surgical and expectant management. And finally, number 5, non-tubal criteria.
All right, Section 1, Diagnosis and TVS Signs. Let's figure out how to actually identify an ectopic.
Now, these original source notes brilliantly lay out the clinical approach. Monulo, a patient comes into your clinic presenting with the classic triad, amenorrhea, bleeding per vaginum, and abdominal pain. Your very first step, a simple UPT. It's actually positive in 99% of cases. But the investigation of choice, that's going to be transvaginal sonography, or TVS. Let's digitize what we actually see on that ultrasound to really lock it into our memory.
Okay, so when you're doing a TVS, you might spot the tubal or bagel sign, that's a gestational sac without a yolk sac. Or you might see the famous ring of fire, which just points to hypervascularity around the ectopic. Or you might simply just see an empty uterus. But listen up, here is a direct high-yield NEET PG MCQ pearl for you. What is the single most common sign? It's actually a complex adnexal mass, and that's simply because of areas of hemorrhage. Exam ke liye yaad rakhna, a complex adnexal mass is your most common TVS finding.
Moving right along to Section 2, the beta-HCG algorithm and finding that critical titer.
The critical titer for visualizing a gestational sac is 2000 IU. So if your patient has an HCG value of greater than or equal to 2000 and you see absolutely no gestational sac in the uterus, boom, that's an unruptured ectopic. You're heading straight from medical management. But what if the HCG is less than 2000 and the uterus is empty? Ectopic confirm ho gaya kya? No. It could just be a super early intrauterine pregnancy. The golden rule right here is, wait. You repeat the beta-HCG after 48 hours.
After those 48 hours pass, here's exactly what we're looking for. If it's a normal live intrauterine pregnancy, that HCG level is going to nearly double, meaning a 33 to 60% rise. If the level decreases, you're looking at an abortion or non-viable pregnancy. But dhyan dena, if there's a sluggish, really slow rise of less than 33%, that is the absolute hallmark of an ectopic pregnancy. A sluggish rise literally means ectopic. Concept clear?
All right, Section 3, Medical Management. Let's get into the rules and protocols.
So the source material here lays out this massive list of prerequisites and drug protocols for handling this medically. I know it looks highly complicated at first glance, but don't stress. We're going to break this down into very simple, bite-sized, high-yield bullet points right now. To manage medically, you absolutely must tick these specific boxes. First, it's got to be an unruptured ectopic. The patient's vitals got to be stable. Family is not completed. The beta-HCG must be less than 5,000 IU, and the sac size has to be less than 4 centimeters. Also, cardiac activity should be absent. But wait, here is a massive clinical pearl for you. If cardiac activity actually is positive, is that an absolute contraindication? Bilkul nahi. Provided the size is less than 3.5 centimeters, you can still try, but just keep in mind that the risk of failure goes up significantly. Our magic bullet for this is methotrexate, given intramuscularly. The dose you need to know is 50 milligrams per meter squared or 1 milligram per kilogram. Notice that for ectopic pregnancies, we strictly use single-dose therapy. This is a huge high-yield point for your exams, because in conditions like choriocarcinoma, you'd use a multi-dose therapy alternating with folinic acid, but for ectopic, single dose only.
Following up on this single dose requires a very specific protocol. It's day 1, day 4, and day 7. On day 1, you measure the HCG and you give that entire MTX dose. On day 4, you measure the HCG again, and on day 7, you measure it one more time. We compare day 4 and day 7 to estimate the actual drop in levels. But you might be wondering, why aren't we checking the drop from day 1?
Well, the source notes chart out this exact algorithm for evaluating success or failure. Let's go ahead and translate this complex flowchart into a super simple 15% rule to answer that exact question.
Guys, this rule is pure gold for your exams.
Success means you see a greater than 15% fall in HCG strictly between day 4 and day 7. If it falls less than 15%, the dose was inadequate. You're going to repeat the dose, making that your new day 1, up to a maximum of 3 times. So why don't we look at day 1 to day 3? Because a rising HCG between day 1 and day 3 is actually completely normal. It happens because that dying ectopic sac is releasing its stored hormones. Examiners love to set this trap, so don't panic and rush your patient to surgery on day 3.
Section 4. Surgical and expectant management. Let's look at the alternatives.
When you do have to head into surgery, laparoscopy is your gold standard, and you have a very clear choice to make. If the family is not complete and the ectopic size is small, so less than 4 centimeters, you're going to perform a linear salpingostomy. You use hydrodissection, gently remove the pregnancy, and leave the tube totally intact to preserve fertility. But if the family is complete or the ectopic is massive, like 5 centimeters or more, you must do a salpingectomy. You just remove the tube entirely.
And just briefly, sometimes we do absolutely nothing. This is expectant management, simply our wait-and-watch approach. We only do this for spontaneously resolving ectopics. The criteria here are super strict. The HCG must be very low, less than 200 IU. It must be dropping spontaneously on its own, and you must see absolutely no gestational sac in the tube on ultrasound. Rare case hit, but highly testable.
Moving into our final stretch, Section 5, Non-Tubal Criteria and Special Ectopics.
The final hurdle in our source notes details the precise anatomical and eponymous criteria for non-tubal ectopics. Honestly, memorizing these names and criteria is non-negotiable for a top score. So let's break down the anatomy together.
First up, we have the classic trap, corneal versus angular pregnancy. A corneal pregnancy happens right in the interstitium or rudimentary horn, so it is an ectopic pregnancy. Anatomically, it's located lateral to the round ligament. An angular pregnancy, on the other hand, is right near the angle of the uterus, making it an intrauterine pregnancy. It sits medial to the round ligament. So remember, lateral means ectopic, medial means intrauterine. Don't get confused here.
Now for the eponymous criteria. You need to burn these names into your memory for sure. For a cervical ectopic, we use Paulman criteria. For an ovarian ectopic, we use Spiegelberg criteria. And for a primary or first-degree abdominal ectopic, we look at Studiford criteria. Paulman, Spiegelberg, Studiford.
Let's rapidly fire through the distinguishing features of each. Palmer-Ullman criteria for a cervical ectopic means you'll see painless bleeding with a closed internal os but a partially open external os. Spiegelsberg for ovarian requires perfectly normal tubes with actual ovarian tissue present in the gestational sac on histopathology. And Studiford for a primary abdominal ectopic requires normal tubes and ovaries and crucially an absent uteroperitoneal fistula. ये सब एकदम clear होना चाहिए.
We've got one final massive point on special types. Heterotopic pregnancy. This is a twin pregnancy where one baby is normal intrauterine and the other is an ectopic pregnancy. Listen carefully here. This is so important. Methotrexate is strictly contraindicated. Why? Because if you give MTX to kill the ectopic, you're going to fatally harm the normal intrauterine twin. The management here is purely surgical, no exceptions.
Wow, we've covered a ton of high-yield ground today. But before we wrap up this revision session, I want to leave you with a provocative question to really test your clinical anatomy. The notes mention that a secondary abdominal ectopic is actually the most common type of abdominal ectopic. So if Studiford's criteria define a primary abdominal ectopic, what specific anatomical structures are ruptured or involved to create a secondary one? Think about how a normal tubular ectopic might progress. Go review your anatomy and keep that curiosity firing. Thank you so much for joining this explainer, and I will see you all in the next one.